Hello, my name is Dr. Daniel Lamponta, and I'm a third-year cardiology fellow at Stanford University and a CardioNerds Fit ambassador. I'm looking forward to attending the AHA Scientific Sessions 2024 in Chicago from November 16 to 18, with Early Career Day on November 15. You'll also get to experience QCOR programming and an international symposium on November 15. It's AHA's 100th birthday celebration with new 2024 scientific guidelines and exciting network opportunities. CardioNerds Conference scholars will be there. Register at scientificsessions.org.
And when registering, be sure to use the code NERDS, because if you're among the first 20 to sign up, you'll receive a free 1-year AHA professional membership. And with that, let's get to the show.
Welcome, CardioNerds. My name is Gurleen Kaur, and I'm a cardiology fellow at the Brigham and Women's Hospital and co-chair for this Cardio-Rheumatology series. Today, we're diving into a hot topic in cardiology: inflammation for cardiovascular risk reduction. It's a tremendously exciting time in this field, and I can't wait to discuss more on today's episode. So let's just get started. I'm happy to introduce my series co-chair, Dr. Rick Ferraro, who recently graduated from Cardiology Fellowship at Johns Hopkins and is now at the University of Michigan for Cardiovascular Imaging Fellowship. Rick, I'm so excited to have this discussion with you today.
Thanks, Gurleen. Can't wait for this episode. So much to learn today, so exciting. I was saying this earlier, but I took echo boards earlier today. And so this is a nice little change of pace here. I'm really excited. And so what I'm going to do next is introduce our lead for this episode, Dr. Nidhi Patel, a CardioNerds Academy Fellow and Internal Medicine resident at Emory, applying for Cardiology Fellowship this year. She spent a year at the NIH under the mentorship of Dr. Nehal Mehta, exploring cardiometabolic health in patients with psoriasis, and is passionate about exploring residual inflammatory risk in patients with chronic inflammatory disease / South Asian populations. Nidhi, welcome.
Thank you so much, Rick. I'm so thrilled to be here, introducing a true expert and luminary in this field, and someone whose papers I have cited several times, Dr. Paul Ridker. Dr. Ridker is the director of the Center for Cardiovascular Disease Prevention and Eugene Braunwald Professor of Medicine at Harvard Medical School. He's renowned for over 30 years of groundbreaking work on inflammation and cardiovascular disease, contributing to countless critical publications and leading to over 300,000 citations of his work. Dr. Ridker is also a principal investigator of the ZEUS trial, testing the role of ziltivekimab for secondary ASCVD prevention. This trial was supported by the CardioNerds Clinical Trials Network, designed to pair equitable recruitment with fit career development. Dr. Ridker, thank you for your support and mentorship to CardioNerds through this program. We are so proud to welcome you to the CardioNerds podcast. It's a true privilege to speak with you today.
Well, Nidhi, first of all, thank you for the very flattering introduction. And I should actually thank the CardioNerds. They were terrific in the ZEUS process. I learned a lot about how your group works, and it was really a lot of fun to work with so many young and invigorating people, eager to learn a lot of new things. Rick, congratulations on the boards. I'm sure you passed today. And Gurleen, it's a pleasure to know that there's a lot of young, smart folks at the Brigham. As I said earlier, make sure my friends take good care of you. But hey, it's a lot of fun to be here with you this evening.
Thank you so much, Dr. Ridker. And with that, we can dive into our first case from the CardioNerds clinic today. So we'll be seeing a few patients. So first up, we have Miss Anna Flame. She's a 62-year-old woman who has been following in the clinic for the last few months. When she first came to us at the CardioNerds clinic, her blood pressure was 160/98, her LDL was 150, and her calculated 10-year ASCVD risk score was 14% by the pooled cohort equations. She was started on blood pressure medications as well as a high-intensity statin. 3 months later, her blood pressure had improved to 125/85, and her LDL had also improved to 65. We usually order an LDL in all of our patients, but a lot of folks that might be listening into this episode, primary care physicians or cardiologists, might not be measuring inflammatory markers for primary prevention. Dr. Ridker, can you discuss with us a little bit about the guidelines and what they say about measuring high-sensitivity CRP for primary prevention and how you might approach residual inflammatory risk in patients like Ms. Flame, who we're seeing today?
I see a lot of patients like Ms. Flame and Mr. Flame, I suppose. And it's a great question about what do we really screen for when we're trying to do prevention in a broad context. And I would argue we can't treat what we don't measure. We all measure LDL cholesterol. Of course we do. It's in our guidelines. It's been in our guidelines for a long time. Lowering LDL cholesterol is the most important thing we do from a pharmacologic perspective, along with lowering blood pressure, which you've already done here. But the reality is we've known for 25, 30 years now that inflammation and hyperlipidemia combine and are synergistic with each other in this disease process. In my clinic, everybody's going to get a high sensitivity CRP measured. Our guidelines have advocated for that for quite a few years, mostly as a tiebreaker. If you're considering where on the scale might this patient be to initiate some therapies. But my personal view is, again, if you don't measure something, you can't treat it. Imagine treating that blood pressure without actually knowing the blood pressure. We would all laugh. Imagine treating the LDL cholesterol without actually knowing what it was. We need to target our therapies to what our patients' underlying personal biologies are. And it sounds like Ms. Flame has hyperlipidemia. You got that under reasonable control. She has hypertension. You got that under reasonable control. But I won't be surprised at all if she also has an inflammatory problem. And at least so far, we don't know it.
Thank you so much, Dr. Ritker. That was a great overview of how we can think about biomarkers and the importance of measuring what we're trying to use for risk stratification. Could you talk to us a little bit more about the Jupiter trial and your work and how that trial has led us to more information about the use of high sensitivity CRP?
Sure. So a lot of our work indeed has been in primary prevention, and actually a lot of it has been in women. I'll go back before Jupiter, as far back as 2000. So that's 24 years ago. We had a major New England Journal paper about the women's health study and how in that setting, high sensitivity CRP predicted risk at least as well as LDL cholesterol, and that the two were synergistic with each other. You couldn't predict A from B. And it began an exploration of the idea that if we want to really target and treat inflammation, we've got to measure it. But again, measuring something and knowing they're at high risk is not the same as knowing you should treat it. Think about triglycerides. We're 40 years into the triglyceride story. Certainly it's a marker for risk, but we still don't know if lowering triglycerides necessarily lowers risk. HDL cholesterol clearly inversely predicts risk, but again, we haven't had definitive evidence that raising HDL matters, at least not yet. So we decided we would start doing some clinical trials to understand this process. So you asked about Jupiter. Jupiter is really an interesting story. I wrote the Jupiter protocol in about 2000. We knew that CRP predicted risk. The guidelines back then, by the way, for primary prevention said if your LDL cholesterol was above 160, bring it all the way down to 130. That was our guidelines. Well, we said, half of all heart attacks and strokes occur among people who have effectively normal cholesterol level. So why are we avoiding therapy when all these heart attacks and strokes are occurring in people who we missed? So Jupiter says, we'll only randomize patients whose native LDL is below that treatment target. So they had to have an LDL below 130. The average is only 100. And this is in 2000. And then we said, let's give them a high intensity statin. That was very controversial. So we gave 20 milligrams of rosuvastatin to patients whose LDLs were already only 100, but they all had to have a high sensitivity CRP greater than 2 milligrams per liter, which put them at increased inflammatory risk, or what we now call residual inflammatory risk. Jupiter is quite an interesting study. We had nearly 18,000 patients globally. In 2008, by the time we finished the trial and presented it, we had a 44% reduction in major adverse cardiovascular events, greater than 50% reductions in heart attacks and stroke. Remember, we get pretty excited today about 10, 15% relative risk reductions. Well, these were cutting rates in half. And we had a 20% reduction in all-cause mortality. So Jupiter said, look, if a patient has underlying vascular inflammation, they need to be on a statin irrespective of their LDL cholesterol level. And that really is when the guidelines began to change and people began to recognize measuring inflammation, high sensitivity CRP is not just a method to predict risk. It's actually a biomarker that we need to consider lowering. We had shown as far back in 1998 that statins were lipid-lowering drugs that had additional anti-inflammatory properties. And all of you as current fellows and residents are taught that lowering CRP is part of what statins actually do in addition to their LDL-lowering properties. So Jupiter really begins this process. But I should say in retrospect that Jupiter was not a test of the inflammation hypothesis of atherothrombosis. Jupiter was a very much necessary step along the pathway to get where we are today. But remember, we were using statin. We were using a drug that lowers LDL cholesterol greatly in addition to lowering CRP. So while the trial said, aha, people with inflammation need to be treated, guidelines change. We now give statins to far wider groups of patients, but the trial was confounded, obviously, by the fact that we both lowered cholesterol and lowered CRP. So we had to figure out a way to do trials that would specifically lower inflammation without changing the cholesterol values. And that's, of course, what CANTOS became.
Thank you so much, Dr. Ridker, for that deep dive into Jupiter. We wanted to continue our case a little bit with more context and ask you a couple more questions. Miss Flame notes that she tries to eat well, but she often eats fast food for convenience and for cost. She gets exercise primarily from walking to and from work, and when you look at her phone health app in clinic, she averages about 2,000 steps a day. She used to smoke a pack of cigarettes per day, but has been able to cut down to 2 cigarettes daily and is eager to quit entirely. Her high sensitivity CRP comes back at 5 milligrams per liter. Dr. Ridker, considering her lifestyle and the high sensitive CRP, what evidence based lifestyle prescriptions would you recommend to help reduce her residual inflammatory risk? And how would this compare to her residual cholesterol risk?
Sure. So it's very important to start with the core fundamentals of good preventive cardiology. And you haven't given me her body mass index or her weight yet, but I'm going to guess it might be a little bit increased. It might even be reasonably increased. An elevated CRP tells us that at patients at high risk, CRP levels do go up with body mass index. They do increase with smoking. They do increase with a sedentary lifestyle. And, it's crucial that our patients hear from us modeling of behavior. If you were to sit in my clinic with me, you would see tennis rackets, you'd see sneakers in the corner. My patients have a real sense that this physician actually exercises every day. There's no way you can walk out of my office not knowing that. We need to get her to completely stop smoking, and we should support her in that. It's a very difficult thing to do. If you have friends or family who've been smokers, it's really a tough thing to do, but we have to get her there. And I think, trying to get her to eat better, mostly plants, would be a good idea. So we use CRP. It's quite elevated here. 5 milligrams per liter would put her almost in the 95th to 97th percentile for North Americans. And we want to tell her that we're going to work with her to help her with the things she needs to do. You've already put her on a couple of drugs. She's already on a statin. She's already on some blood pressure lowering medications. But I think she's probably also going to have to face the reality that this inflammation problem is real. You haven't told me her ethnicity either. That's important. There are folks from around the world whose backgrounds might be related to certain populations. A common one are folks whose families ultimately derive from either India, Pakistan, places where, there's this sort of genetic increase in metabolic disease, as is also true in parts of South America and Mexico. And these things really do matter in how you put together the big picture. But it's all about primary prevention at this point and encouraging her to do these good preventive measures.
Thanks so much, Dr. Ridker. And that makes a ton of sense. I think that's something that we're all familiar with now and something that, as someone that's interested in prevention is really exciting to me. What really struck me is a comment that you made earlier about the guidelines in 20 plus years ago saying to statins really weren't recommended, it sounded like, until an LDL of 160, which is, wow, that just puts things in such perspective, given the tools we have now. And obviously the guideline recommendations have changed tremendously. And so, wow, that perspective is amazing. But I want to switch gears here a little bit and say that Miss Flame came to clinic with a history of prior STEMI and an RCA drug-eluting stent placed 3 months prior. Since then, she's been on high-intensity statin, which is important, as we've discussed, as well as dual antiplatelet therapy, taking them daily. Dr. Richter, in this case of secondary prevention, what evidence supports the use of inflammatory markers, hs-CRP being one of them, for further evaluation of this case, now 3 months away from her STEMI? And you had touched a little bit on CANTOS, but I'd love to hear how you recommend approaching the management of inflammation in acute, semi-acute, or chronic periods for prevention.
Sure. So we could have quite a discussion about guidelines. I sometimes think that it's as if they are the bare minimum and quite a bit behind all the science that we know to be true. And there's political reasons why that might be. But we can hold that for another conversation. So this patient now is clearly in a secondary prevention mode. So we've really shifted her. You say she's post-STEMI. And I think you said she had a stent put in, so she's going to be on some antiplatelet agents as well at this point. Look, a high sensitivity CRP, while a lot of the data was generated in primary prevention, everything is also true, just ramped up in secondary prevention. So patients who are post-MI, post-CABG, who are post-angioplasty, who have any sort of chronic peripheral arterial disease or anything that would put them into a cardiologist's office, if their CRP is high, hers is, despite being on a high-intensity statin, she has identified herself as classical residual inflammatory risk, which by definition means an elevated CRP despite being on high-intensity statin and despite having her LDL quite well controlled. She told me she was down to 65 already. So that is where we're mostly concerned. But again, we need clinical trial evidence telling us that if we target the inflammation per se, we can lower cardiovascular risk. So that's where CANTOS comes into play. So around 2010, at the end of Jupiter, we decided we needed to do a clinical trial looking at truly testing the inflammation hypothesis of atherothrombosis. Now, the drug we used is called canakinumab. It's a monoclonal antibody that targets interleukin-1 beta. So for those who may not be completely up to date on this whole process, there's a central signaling pathway of innate immunity that's extremely important for atherosclerosis. It moves from something called the NLRP3 inflammasome, which is where IL-1 and IL-18 are upregulated and activated by certain enzymes inside standard cellular systems that we all have to fight infection, to fight crystalline structures, to fight gout. But it's overactivated in patients with atherosclerosis. We'll let IL-18 go for the conversation today, but it is important. IL-1 beta upregulates IL-6. IL-1 and IL-6 together have lots of direct effects on the vascular endothelium that are adverse. And they happen to go down to the liver and pump out our biomarker, the CRP. Now remember, CRP is not necessarily a player in the process. It's a very nice downstream, simple to measure biomarker that says, aha, there's a problem upstream in this NLRP3 inflammasome. So anyway, we decide we're going to target interleukin-1 beta. CANTOS was a very complicated clinical trial. It's secondary prevention. Again, everybody to enter the trial had to have residual inflammatory risk, which meant a hs-CRP greater than 2. Ms. Flame would have easily qualified because of her known atherosclerotic disease. So they're getting very aggressive lipid lowering. Many of the patients already had angioplasty, bypass surgery, et cetera. They're all getting aggressive standard of care. And we actually divided it into 3 different doses of canakinumab. I would call it low, middle, and high for our purposes today, against placebo. And there was real anxiety about this. A lot of the investigators said, we're nervous about anti-inflammatory drugs. What's the difference between anti-inflammatory and immunosuppressive? But here we are many years later, 10,000 odd patients were randomized. And CANTOS really is a marker in the history of this field because we get definitive evidence that if we give this interleukin-1 beta inhibitor, we can get a 15 to 17% reduction on top of aggressive statin in major adverse cardiovascular events. This data was presented at the ESC in 2017 to really a large audience and a lot of interest because we now had definitive evidence. And I point out 2017 for a very important reason. That's the exact same year the PCSK9 trials came out. And of course, they also delivered a 15 to 17% relative risk reduction on top of statin therapy. But they did it by dramatically lowering ApoB and LDL cholesterol. We got the same reduction in events, what really matters to the patient, but we didn't change LDL or ApoB at all. What we did is we lowered IL-6, we lowered CRP, and we lowered cardiovascular event rate. And importantly, there was no change in HDL, no change in LDL, no change in triglyceride, no change in blood pressure, no change in A1C. We just targeted inflammation. So CANTOS tells us, aha, there's a whole new way of addressing cardiovascular risk reduction with a caveat. And the caveat's a very interesting one from a scientific perspective. My interests quite broadly include inflammation biology and systems biology. And we had designed CANTOS to look not only at cardiovascular events, but also at certain cancers. Certain tumors have a underlying inflammatory component to them. The most prominent of these tumors is non-small cell lung cancer, which of course our cardiology patients get because they often are smokers. And CANTOS simultaneously showed, in fact, we presented the data back to back when we published it back in 2017. We had a 50-60% reduction in incident lung cancer. So what actually happened from a historic perspective is CANTOS proves the inflammation hypothesis of atherothrombosis, generates tremendous excitement in terms of alternative ways beyond cholesterol, beyond blood pressure reduction to actually save our patients' lives. But the drug did not become available because it's the sponsor of that trial, Novartis, that I'm incredibly indebted to for seeing the biology with us, decided to take the drug into oncology. And that's the main reason why you can't give canakinumab today for atherosclerosis, It is on the market. It's been on the market for a long time to treat some very rare childhood IL-1 beta overexpression syndrome. So canakinumab traditionally has been a orphan drug for things like Muckle-Wells disease and CAPS and NOMID. But for adult atherosclerosis, we now had proof of principle. It clearly worked, but we couldn't prescribe the drug. And that left us with some holes that we had to figure out a way to fill.
Thank you so much, Dr. Ridker. CANTOS is such an important trial in the field, and it's so interesting hearing about not only designing the trial, but also some of the things that you dealt with after the results of the trial came out. I actually wanted to play a game now and take a brief intermission. I'm calling the game Sequence the Inflammatory Cascade. You kind of touched on some of the key players of inflammation already, but I'm hoping that you can put them in order and describe the cascade for our listeners. Are you ready, cardio nerds? Let's get started. The key players are IL-1 beta, cholesterol crystals, hs-CRP, IL-6, and the NLRP3 inflammasome.
I think this is also a CardioNerds first.
Okay, so let's put these in order that at least I would put them in. And for the simple answer, it would be crystals first, the NLRP3 inflammasome second, IL-1 beta third, IL-6 fourth, and downstream C-reactive protein coming out of the liver fifth. But we have to talk about why and what's going on here. So what is this crystals all about? What the NLRP3 inflammasome does, among other things, is it recognizes foreign bodies, foreign objects, things that our innate immune system says, aha, these don't belong here. The ones that you know about well are LPS polysaccharides, things that can trigger this when an infection occurs. The one that, as internists, everybody knows is gout. So it's not circulating uric acid that triggers the inflammasome, it's crystalline urate. So uric acid crystals in, say, a big toe would activate the inflammasome. One of the big insights in this field was that cholesterol crystals, the stuff that we shatter every time we go to the cath lab, we're sending lots of crystals downstream. The cholesterol crystals themselves are seen as foreign. Again, it's really interesting biology. It's not the circulating milligrams per deciliter, it's the crystalline structures themselves. And these activate this inflammasome and it says, aha, these are foreign. And that in turn, through caspase enzyme activation, upregulate a certain set of enzymes. For the simplicity today, we're going to call one of those interleukin 1 beta. A guy named Charles Di Nerello is the father of this field. He discovered IL-1 beta many, many years ago when he was studying fever, because this is also the pathway for febrile diseases. Interleukin 1 beta has some direct effects on the vascular endothelium. It also upregulates the central signaling pathway, interleukin 6. So that's one step downstream. We'll come back to that when we talk about ziltivekimab and the ZEUS trial. And both IL-1 beta and IL-6 have a host of effects on the vessels that can be adverse. But IL-6 in turn will upregulate the production of our biomarker, the high sensitivity CRP, predominantly coming out of hepatocytes in the liver. So that would be the bottom of our cascade. So we have a really interesting piece of biology. And the question is, if we inhibit that biology, which is what CANTOS was all about, we gave a drug that blocked interleukin 1 beta. So we greatly reduce production of IL-1 beta. In turn, that lowers IL-6. In turn, that lowers CRP. In fact, we would publish a whole series of papers showing that the benefit of canakinumab, the IL-1 beta inhibitor in the CANTOS trial, was less related to the dose of the drug as it was to the magnitude of either IL-6 reduction or CRP reduction that the individual patient got. In other words, the more robust the anti-inflammatory response the patient received, the greater their relative risk reduction for heart attacks and strokes was. And in fact, we had patients who, despite getting canakinumab, really didn't lower their IL-6 or CRP very much at all. They looked a lot like placebo. And this was a big issue for personalized medicine or sort of predictive medicine, the idea that we really would want to target this biomarker to get greater reduction. But that's not so surprising. Same thing holds for LDL cholesterol. We know that the greater LDL reduction, the better off you are. We know that with blood pressure reduction, you got to get it down or else you don't get the benefit. Same idea here. You want to lower IL-1, you want to lower IL-6, and the more you do, seems to be the greater benefit that we get.
Thank you, Dr. Ridker, for playing along with our game of Sequence the Inflammatory Cascade. It was so great to hear you walk us through not just the sequence of the cascade, but also the deeper dive into the history and details of each of those components. And I'll definitely have to listen to the recording again so far to take in all the pearls and knowledge that you've shared. It's really remarkable to see how studying the biology of inflammation has led to such breakthroughs on addressing residual risk for ASCVD. And now that we've reviewed the inflammatory cascade, let's dive a little bit deeper into the therapies targeting this cascade that we can use to reduce Miss Anna Flame's residual inflammatory risk. Dr. Ridker, can you summarize for our audience what therapies are available targeting this inflammatory cascade, as well as therapies that are on the horizon?
Sure. So it is the really important question here. First, I want to reemphasize what we already talked about. Just like in primary prevention, Ms. Flame, who's now had her STEMI, she needs aggressive smoking cessation. She should not have another cigarette the rest of her life. In addition to everything else bad it's doing, it's upregulating NLRP3 activation in the lung, so that's really bad. She's got to eat better. She's got to get her cholesterol down. She's got to exercise. She's got to get some of that weight off. So all these things are really going to matter. But on top of that, we now have proven pharmacologic therapies, and we have several therapies coming to us that can lower that risk. Let me start with what's already FDA approved. And I think that's probably the most important part. So investigators in Australia and in Canada were also thinking about inflammation reduction the same way we were. And they had shown that common generic drug, low dose colchicine, and the low dose is important. Let me give you the dose. It's 0.5 milligram once a day, which is lower than the typical dose that we give in the United States. And it's significantly lower than the dose you might give to treat acute pericarditis or acute gout, where you typically give pretty good size wallop of colchicine just for 2 or 3 days until the inflammation is gone. This is a chronic low grade use of colchicine. A series of clinical trials were done. They're called Lodoco, low dose colchicine, or Lodoco 2, the second Lodoco trial, and the Colcott trial. Lodoco 2 was very similar to Canto in that patients had stable atherosclerosis. Most were 6 months or so out from their qualifying event. And quite remarkably, they got a large reduction in hard vascular events. It was a 25, 30% relative risk reduction. Drug was very safe and very well tolerated past the first couple of doses. So one of the issues with colchicine to tell your patients is you may get some gastrointestinal upset for the first 2 or 3 days. Just get through it. The vast majority of patients who take this drug do just fine on it once they've been on it for, say, a week or so. But the way the guidelines work and clinical trials work, we want to have more than just one study. So the second trial, Colcott, was also patients with stable atherosclerosis, but they were closer to their qualifying MI. They were within 30 days of that event. Most of them were about 12 to 15 days. So again, they're very stable. They've been discharged from the hospital. So again, in my mind, it's stable atherosclerosis. And that trial also delivered a roughly 20-25% relative risk reduction. The reason I'm citing the magnitudes of those risk reductions is important. All of us lower LDL very aggressively. But, our secondary prevention trials with ezetimibe have only delivered, 6 or 7% relative risk reductions. The PCSK9 inhibitor, 15, 16, 17% relative risk reductions. Geez, the two colchicine trials are in the 25 to 30% range. So getting Ms. Flame to consider low-dose colchicine would be, in my mind, a very good idea with a few caveats. All drugs come with some adverse effects, and colchicine is metabolized by the liver and by the kidney. So I would be very hesitant to give her colchicine if she had significant abnormalities of her AST and ALT, typically, 3 to 5 times upper limit to normal. And I'm pretty hesitant to give colchicine out to a patient who has moderate to severe chronic kidney disease. In fact, I'm quite conservative. I pretty much kind of feel like if the GFR is less than 60, I might just think about something else. I know that it's actually safe at a GFR of 60, but at the Brigham, I'm a referral-based cardiologist. The patient goes back to the community and they might be on that drug for 5, 10, 15 years. And if the GFR was at 45, but now it's at 30 or 25, the patient could well get in trouble and someone might forget that this is not a drug for chronic kidney disease. By the way, there's also a few drugs that give some relative short-term contraindications. Fluconazole, ketoconazole, the CYP3A inhibitor, but they're pretty rarely used. I should tell you, though, we live in a fairly litigious society, but other parts of the world have been giving low-dose colchicine for 20, 30 years with no problem at all. That would be if you practice medicine in Lebanon or Syria or Turkey or Israel or Morocco or North Africa, you'd be completely familiar with this drug because it is the standard drug to treat familial Mediterranean fever, which is incredibly common in those parts of the world. And patients take low-dose colchicine daily for decades. There's been no increased risk of cancer, and they don't really worry about any of the stuff we just talked about. So the drug is pretty safe, and in these trials was pretty safe. And what's really exciting is that the US FDA, in the middle of last year, pretty much on their own, said, you know what, we're going to go ahead and label low-dose colchicine for the prevention of recurrent cardiovascular events because so few American cardiologists and American internists are actually aware of these data. And by the way, think about it. Both the Lodoco 2 and the COLCOT trial, they were published in New England Journal of Medicine. They're both randomized, double-blind, placebo-controlled trials. I would argue, and this is probably a good point for CardioNerds, that if those trials had been supported by major pharmaceutical support, every one of you would know about it. Every one of you would have multiple copies of the paper. Every one of you would be marketed heavily. But these were trials that were funded by government agencies. There's really not any significant backing for low-dose colchicine in any sense of the word. You're not going to see advertisements on television for this drug. So you actually have to say, aha, what's best for my patient? And the US FDA, not influenced by marketing, said, we need to go out and actually tell doctors that there's a new way to treat inflammation that really works really well. By the way, there's another trial that just came out called CONVINCE. CONVINCE was a stroke reduction trial. Again, same idea, elevated CRP, history of stroke. They showed very nicely, yet again, that CRP levels come down when you treat with colchicine. They had a non-significant, roughly 20-25% reduction in stroke, but in a meta-analysis of all the stroke data, they got the exact same risk reduction for ischemic stroke as we have for cardiovascular events. So I think the neurology community is also going to wake up to this idea that, hey, there's an inexpensive drug that I have to ask myself, why aren't I using it? And so if Ms. Flame has a pretty preserved kidney function and no obvious liver disease, in my clinic, she'd probably get introduced to low-dose colchicine.
Yeah, Dr. Ridker, that was really just a tour de force. It's going to be one of those things where I have to go listen back, and I'm excited to do so because there was so much there and so much to take apart. The points you make about using colchicine in clinic and that it still really hasn't, at least in the US, had a tremendous amount of uptake is really eye-opening and really important. To kind of follow up on that, we'd love to discuss a little bit more chronic inflammatory disease and those who we know, patients like those with rheumatoid arthritis and others, are at higher risk of atherosclerosis and major adverse cardiovascular events. Since these patients are often first seen in a rheumatology clinic rather than cardiology ones, we'd love to get your opinion on how should we best approach them, or I guess how should internists or rheumatologists approach them to hopefully prevent downstream cardiac issues? Is this something that you would screen patients in some way, or is that something that you'd recommend keeping on their radar? Any thoughts on that?
Sure. So, Nidhi, I think you said that you worked at the NIH with my friends there who are very interested in psoriasis research with Nahal Mehta and his colleagues. And there's this burgeoning field that we now call cardio-rheumatology. It's really very exciting. I'm old enough to remember when cardio-oncology was begun. And I'm just seeing over the last 3 to 5 years, people around the country now sort of gravitating towards cardio-rheumatology. And it's exactly for the reasons you're talking about. So let me summarize very quickly. Every disorder that we would categorize as auto-inflammatory or autoimmune, I mean, every single one, ranging from psoriasis to Addison's disease, to lupus, to scleroderma, to Crohn's disease, to inflammatory bowel disease, every single one has now been shown to have elevated cardiovascular risk on top of the risk you would predict based on the usual thing. That doesn't surprise me at all. It's because from a systems biology perspective, I think about inflammation from any cause, if you like, being seen or felt, if I anthropomorphize it, by the vascular endothelium as an adverse process that drives atherosclerosis. So all those patients have elevated cardiovascular risk. And of course, many of those patients, particularly if they have significant rheumatologic disorder, are being treated with some very interesting drugs. TNF inhibitors, IL-6 inhibitors, lots of novel ways of inhibiting the immune system. That's really been a revolution in the treatment of patients with, say, Crohn's disease or inflammatory bowel disease and the like. And we in cardiology are just beginning the process of trying to figure out whether or not some of those drugs might be effective for our patients. So that's actually a wonderful introduction to the clinical trial that the CardioNerds were so helpful in helping us enroll and think about, which was a clinical trial that's ongoing right now called ZEUS. Full disclosure, I am the co-PI of ZEUS. ZEUS is funded by Novo Nordisk, the folks who bring you all the weight-lowering drugs. But ZEUS is using a very interesting drug called ziltivekimab, another mouthful. Ziltivekimab is a monoclonal antibody that targets interleukin-6. It actually targets the interleukin-6 ligand itself. So it's a little different than an interleukin 6 receptor antagonist that you might be more familiar with if you ever had to treat, RA or something with tocilizumab or something like that. Ziltivekimab itself has an interesting history. It was developed by colleagues of mine about 20 miles west of my office in Boston in Waltham, small company called Corvidia. And I was having dinner with the principals, and they were developing this drug for the use of anemia, which it worked for. And I said, given the results of Cantos, which was an IL-1 inhibitor, and if the benefit of Cantos was related to the magnitude of IL-6 inhibition, which it was, why don't we just use this drug and see if we can't lower event rates with IL-6 inhibition directly? And I said, remember, colchicine is a drug that I don't want to give to patients with chronic kidney disease. So Zeus is born, and Zeus is literally a fully enrolled 6,000 patient multinational trial of patients who have known atherosclerosis, so it's secondary prevention. They have chronic kidney disease with a GFR range or a UACR range, and I'm not comfortable giving colchicine, so I'm not giving them colchicine, but they all have residual inflammatory risk, so the high sensitivity CRP, again, is greater than 2. Zeus is completely enrolled. Thank you, CardioNerds. Very helpful. You guys were actually a blast to work with. We're now in the follow-up process, and I'm guessing that we're probably, I don't know, a year and a half to 2 years away from knowing the result. And by the way, Zeus has dual endpoints. So as I said, I'm the co-PI. I'm sort of driving the cardiovascular side of this. So the primary endpoint is, can we reduce this very high risk? Remember, patients with chronic kidney disease are a real dilemma. They're some of our highest risk patients. We give patients with CKD statins, but as I think you're probably aware, statins are less and less and less effective as the GFR declines. In fact, the only clinical trials that ever showed statins not to work were in the setting of dialysis. Yet, as the GFR falls further and further, the inflammatory markers become more and more important. Without going into details, there's a major study done by the NIH called CRIC, which is a chronic renal insufficiency study that showed that CRP and interleukin 6 were the most powerful predictors of bad outcomes in the setting of chronic kidney disease. So it makes sense to us to target inflammation there. And again, we're concerned about infection, we're concerned about side effects, but if ziltivekimab can prove yet again to lower vascular inflammation, and if the hypothesis coming out of Cantos, which was the magnitude of the IL-6 reduction, really drives the benefit. This is a little inside baseball, but I guess that's partly what CardioNerds is all about. In Cantos, the IL-1 beta inhibitor lowered CRP and IL-6 on average about 35 to 40%, and we got a 17% reduction in events. Well, ziltivekimab will lower IL-6 by 85 to 90%. And if that data we had about on-treatment IL-6 being the driver of this, in my very optimistic moods, I might say, well, maybe we'll get a double the size of benefit. So wouldn't it be wonderful to have an outcome that says, aha, we got a 25, 30, 35% reduction in risk? We'll see. And we'll know that within about a year. I should say, though, that what's really interesting is that Novo Nordisk, who picked up ziltivekimab and is really interested in moving into the cardiovascular development, they kind of said, well, Paul, what else might we do with this drug as long as we're going to do this study? And myself, along with a group of others, sat down and we said, well, there's a lot of other interesting situations that we're interested in. So one of them is HFpEF, heart failure with preserved ejection fraction. That trial is now up and running. It's called Hermes. Mark Petrie in the UK is the primary leader of that trial. That's very controversial because the role of inflammation in heart failure has been tested previously. My dear friend, Doug Mann from WashU St. Louis, very early on did a TNF inhibitor trial in that setting. It didn't work, but I think Doug had the exact right idea, but maybe just picked the wrong drug. So that trial is now enrolling, and I wouldn't be surprised if we go back to CardioNerds and ask for more help there. And then a third clinical trial being run by our colleagues at DCRI down at Duke is called Artemis. And this is the acute coronary ischemia version of Cantos. So that's this trial that says, well, maybe we should start the inflammation inhibition right at the time of the ACS presentation. Why are we waiting for stable disease? What do we know about this? And we know that at the time of acute coronary ischemia, there's a tremendous burst of this pro-inflammatory response. Well, why not dampen it down right away and see what we get? And so Artemis is just beginning on a global basis. So I got to give Novo Nordisk a lot of credit. They're really going out on a limb, taking three major directions in our world. Chronic atherosclerosis in the setting of chronic kidney disease, that's Zeus. Heart failure with preserved ejection fraction, that's Hermes. And acute coronary ischemia and reperfusion injury on a chronic basis, and that's Artemis. So it's a very, very exciting time for what's going on in my world.
That's incredible, Dr. Ridker. And I mean, again, just an incredible summary of what is going on in the inflammatory space. One follow up I was hoping to ask is so for HFpEF, I get the idea of stabilizing plaque by reducing inflammatory burden, preventing subsequent downstream events. For something like HFpEF, is the goal to have remodeling of the LV? Is that something that we can do? Because it's kind of a damage has already been done scenario to some extent. What are your thoughts there?
Okay, so that's actually a great question and worth our discussing. First of all, let me just say up front, it's highly controversial. And if I was to get 25 of my best heart failure friends in the room, we would discuss this for about 5 hours and we'd all disagree, which is always a good thing, right? That's true equipoise. So even my naysayer friend, I've gotten to agree, well, hey, this is a heck of a good experiment because we have to sometimes do things to find out what truth is. Number two is think about fibrosis for a second. There's a lot of work out there for many years now that has suggested that early on in heart failure, one of the things is stiffening of the LV wall. And that stiffening process ultimately leads to the clinical manifestations of elevated LVEDP and sort of the things we see on echo and the things that our patients feel in terms of shortness of breath. But it also is the beginning of the process of increased fibrosis and increased changes in the extracellular matrix around the heart that leads to chronic severe heart failure, where the cat probably is out of the bed. So we had to make some decisions. It is true, by the way, that CRP levels predict risk of heart failure. In fact, we showed that in CANTOS. Brendan Everett, who's one of the cardiologists at the Brigham, was the first author of data from CANTOS that showed that CRP levels and IL-6 levels predicted incident heart failure hospitalization. And that's been repeated a couple of times now in other settings. We didn't want to do HFrEF exactly for the reason you're saying. We kind of said, well, maybe the cat is out of the bag, and maybe we can catch people with HFpEF that aren't quite at that stage yet and see what's going on there. So that's what we're going to do. And remember that the antifibrotic drugs have not really delivered much benefit. So the question is, if we take this global inhibition pathway against the localized innate immune activation that we think is driving some of this, maybe we can get benefit for those patients. And again, I want to point out in CANTOS, we actually did see a reduction in heart failure hospitalization with the IL-1 inhibitor. It wasn't huge, but it was statistically significant. And so if we think the IL-6 inhibitor will deliver more bang for the buck, so to speak, than the IL-1 inhibitor, at least the biologic bang for the buck, then maybe we'll get a bigger benefit in heart failure. And again, what's wonderful is this sort of synergy between academic science and, in this case, a pharmaceutical company willing to take that gamble. So we're going to find out.
Yeah, that's really exciting. Thank you for the explanation.
Dr. Ridker, thank you so much for that. It's so interesting to think about the role of CRP and IL-6, not only in ASCVD prevention, but also for heart failure. Dr. Ridker, I just wanted to say we're so lucky to have you as a CardioNerds partner and be able to learn from you today. I actually wanted to just share one quick takeaway that I had and then ask you to summarize some of the key takeaways that you would have for us as we tackle residual inflammatory risk in the clinic. So, what I really learned from this podcast is that we're really good at reducing LDL in the clinic, but there are drugs that are available out there that have been shown to have amazing cardiovascular risk reduction as well. And maybe we should be thinking about some of these in clinic, as well as measuring high sensitivity CRP. Dr. Ricker, would you summarize some of the key takeaways that you have for us?
Sure. So first of all, let me thank the three of you and CardioNerds for allowing me the honor of being on your podcast. You guys really do represent the future of cardiovascular medicine in every sense of the word. And one of the things Professor Brownwald taught me many years ago is that it's the older generation that holds back progress. It's the younger generation that's open to the biology and makes things change, and your patients will benefit from it. So first of all, that's just a thank you. Let me give you 6 quick bullets if I can. Number 1. We can't treat what we don't measure. I think we should be having universal assessment of high sensitivity CRP, along with LDL and HDL and triglycerides and GFR and blood pressure. That's number 1. We can't treat what we don't measure. You've got to know what the patient has. And if you don't even know they don't have residual inflammatory risk, how are you ever going to know what to do for them? Number 2 is the biology here. Inflammation and hyperlipidemia both contribute to the development and progression of atherosclerosis. That's crucial to understand. We now teach our Harvard medical students that from the very basic, but some of our older colleagues who didn't know that when they weren't taught that in school have to kind of learn that. Inflammation, hyperlipidemia, they both contribute. Number 3 is low dose colchicine. Again, the dose is 0.5 milligrams once a day. It's the first FDA approved anti-inflammatory therapy for chronic atherosclerotic cardiovascular disease. It works. It's got a large relative risk reduction, but it really should not be given, in my mind, to patients who have chronic kidney disease or hepatic dysfunction. So it's a first. It's good. I would use it. I'm using it more widely, but there are patients who can't take it. Number 4, just as we talked about a minute ago, the ongoing randomized trials, ZEUS, chronic kidney disease, Hermes, HFpEF, Artemis, acute ischemia, they're going to teach us whether novel targeting of IL-6 inhibition itself can safely lower cardiovascular event rates and slow renal progression in our patients. So that's a big one. And by the way, I didn't even mention another clinical trial that's ongoing using a different IL-6 inhibitor that's being given in the setting of dialysis. So extremely high cardiovascular risk setting, but also a setting where there'll be more infection. So that's a risk to benefit ratio 1. Number 5 is basic fundamental good medicine. Diet, exercise, smoke cessation, statins. I should also point out bempedoic acid, the SGLT2 inhibitors, the GLP-1 RAs. All these drugs lower inflammation. All these good habits lower inflammation, and they all lower cardiovascular event rate. So even Ms. Flame, in her secondary prevention mode, still needs reinforcement of good behavioral therapies, diet, exercise, smoking cessation, etc. We don't want to lose track of it. And number 6, perhaps the most important message for the cardio nerd is, look, inflammation inhibition and lipid lowering are not in conflict. These are synergistic therapies. So when you talk to your colleagues, when you talk to older attendings, this is not a challenge to the LDL hypothesis. I'm a very aggressive LDL lowering physician. But again, inflammation inhibition and lipid lowering, they're not in conflict. These are synergistic processes, and colchicine, perhaps ziltivekimab, perhaps other drugs can be given on top of lipid lowering for the exact reason we give the lipid lowering in the first place. We don't give lipid lowering to lower the LDL. We give lipid lowering to lower the risk of having a heart attack, a stroke, and a cardiovascular death. We published some data in the Lancet about a year ago. We looked at 32,000 contemporary patients, all taking high-intensity statin. And we found that the residual inflammatory risk, the hs-CRP, which most doctors still aren't measuring, was by far a stronger predictor of cardiovascular death than was the residual LDL, which everybody's measuring. So again, yes, measure the LDL. But if you measure the hs-CRP, you're going to discover that a lot of patients have a treated or at least not maximally treated inflammatory response. And that's really going to change the outcomes for our patient.
Dr. Ritger, it's been such a great discussion with you here tonight and so many pearls in those 6 takeaways that you gave us. And I'll definitely remember your phrase, we can't treat what we can measure, when I'm seeing patients in cardiology clinic and thinking about risk stratification in my patient panel. It's been a true privilege to hear the perspective of your journey in clinical trials from Jupiter to Cantos to ZEUS and beyond. And thank you so much for helping us put the data from several of these clinical trials into perspective. And it's definitely a very exciting time for inflammation and with new trials. And I'm looking forward to seeing the results of those that you mentioned, such as ZEUS and Hermes and others. As we wrap up tonight, I want to ask you one last question that we ask all of our guests here at CardioNerds. And that is, what makes your heart flutter about cardiology as a clinical trialist and leader in the field of inflammation?
Well, Gurleen, first of all, let me thank you again, along with Rick and Nidhi, for being such wonderful hosts this evening. You know, I became a cardiologist because of one person. That was Eugene Brownwald, who at the end of my internship pulled me aside and said, I think you should be a cardiologist. And I said, okay. And that's pretty much literally what happened. It's all worked out great, and I have loved my entire cardiovascular career from a clinician's perspective, a research perspective, an education perspective. And it's one of those fields where, you know, our patients can actually get better. It's one of those fields where we can really change outcomes through modeling of behavior, all the way through to incredibly aggressive things that our colleagues do in the EP lab, in cath labs, with putting in stents and valves that I couldn't even imagine years ago, to very novel therapies for hypertrophic cardiomyopathy that we're seeing medical therapies for today. It's just absolutely incredible. It's a field where the genetics and where our understanding of molecular biology is rapidly going to clinic. I have to admit, I love being a cardiologist. I think you all have picked a great specialty, and I wish you all absolutely wonderful careers.
Dr. Ritger, thank you so much. And honestly, I think I speak for all cardio nerds in saying it's such a privilege to speak with you tonight. You're truly a master clinician. And in this area, just hearing your perspective on a range of topics with inflammation has been a huge privilege and honor for me. And so Thank you for your time. It's a huge privilege, and we're excited to talk again.
It's been my pleasure. Thank you.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Chu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.